Good evening, everyone, and welcome to Wu Yu's edition tonight, Oculoplastics and TED Advanced Care Update with Dr. Raymond Douglas, MD, PhD. Thank you so much, Dr. Douglas, for being here tonight. Next slide. So I'm your host, Dr. Elise Kramer. So a little bit about Dr. Raymond Douglas, aka the Eye Guy, is an experienced board-certified aesthetic and reconstructive oculoplastic specialist. Patients with thyroid eye disease or TED, Graves' eye disease, previous unsuccessful surgery, cancers of the eyelids or face, and trauma-induced injuries seek Dr. Douglas' expert, customized care at both his primary practice in Beverly Hills and international practice LA Face in Shanghai, China. His expertise in treating difficult cases of disfigurement due to thyroid-associated eye diseases, cosmetic and reconstruction surgeries has made him a highly respected educational and surgical authority for both reconstructive and cosmetic arts of facial plastics. Dr. Douglas graduated with academic distinction from the University of Pennsylvania, where he began his medical training and PhD in immunology and autoimmune inflammatory disorders. He went on to complete a subspecialized fellowship in orbital facial plastic and reconstructive surgery at the UCLA Jules Stein Eye Institute. To date, he has had several prestigious positions at the UCLA School of Medicine, Harbor UCLA Medical Center, Greater Los Angeles Veterans Hospital, Veterans Administration, Ann Arbor Healthcare System, and the University of Michigan Kellogg Eye Center. He is also Chief Medical Officer for Flowmetric Inc., a medical device company developing aging and inflammation testing for the consumer market to launch in 2020. In addition to his private practices, Dr. Douglas is a clinical research author, advocate, and education international, recognized for his groundbreaking research on treatments and restorative surgical techniques for thyroid eye disease. While traditional surgery focuses solely on the functional issues of TED, Dr. Douglas has pioneered a specific technique, aesthetic orbital decompression, aka eye lipo, which addresses both eye aesthetic and function. This precise and artistic corrective approach has enabled patients a significantly quicker recovery time with less scarring and reduced risk of complications. Thank you so much, Dr. Douglas, again for being here, and I really look forward to hearing this presentation.
Thank you so much, and sorry for the long bio, but really appreciate being here and talking a little bit about thyroid eye disease. These are my disclosures, which we've already discussed. So what we're going to talk today is the faces of thyroid eye disease, and I know that there have been some other lectures, in this regard, but I'd like us to, for one, take a step back and to really look at the faces in which we see. And sometimes thyroid eye disease is really subtle. And you can see some photos here where you may or may not even know, unless you saw an old photo of these patients, whether they had thyroid eye disease. And other patients, it screams at you walking in the door. So, it's very important to, take advantage of history, of knowing whether they've had Graves' disease, etc., as we even diagnose thyroid eye disease. And where we're going to spend most of the time tonight is the new novel therapies for actually treating it. So many times in the past, we've been faced with the inability to do anything, which has been incredibly frustrating for eye care professionals. So just as a little background, I don't want to belabor previous presentations, but I think it's important to really understand and think about the history when someone says that they have Graves' hyperthyroidism. Remember, thyroid autoimmune disease is the most common autoimmune disease by orders of magnitude more than any other autoimmune disease. But what happens is that patients often are on levothyroxine or Hashimoto's disease. Graves' disease is slightly less common, but very frequent in the population. And 80 to 90% of patients who have thyroid eye disease have Graves' disease. So it's very important in the review of systems to know whether they are on any thyroid medication, and specifically Graves'. Now, when they're diagnosed with Graves' disease, most patients, 80%, develop thyroid eye disease within 18 months. Well, that also tells you that, in guiding patients, if they've had Graves' disease for 10 years, the chances of having thyroid eye disease develop in the future is actually quite small. There's always a lifetime risk of about 4 to 5%, but it goes down. It's usually in this time in which they're diagnosed with Graves' disease. So that's kind of when you want to keep your antenna up. Anywhere from a 5 to 9 fold frequency increase for females compared to males. And this is going to present in a variety of ways. One of the best ways to ask about this: has your appearance changed? Are you being treated for like a chronic allergy for months of eye redness, months of just redness that won't go away and beginning to look a little different? And that all manifests into the proptosis, the eyelid retraction, which occurs up to 90% of patients. Sometimes the strabismus in about anywhere from 25 to 50%. But also this weird eyelid edema and thickening, and sometimes chemosis and injection that just really doesn't go away with normal therapy, not with artificial tears, not even with steroid eye drops. So it really is just something that lasts. And some patients, this can lead to compressive optic neuropathy, only about 4 or 5%. And I will tell you, I know that everyone worries about that, but it's a slow progression to optic neuropathy. You don't want to miss it, but at the same time, asking them if one eye color vision is different than the other is a great, quick, easy screening tool to at least be aware of any changes and for them to home monitor for any changes. Well, we're going to get into what is this disease. The tissue behind and around the eye and of the face swells because it's being attacked from the body's own immune system. And in fact, it's being replaced by some of these cells that come from the bone marrow. In a very simplistic way, the inflammation from behind the eye and the tissue expansion leads to almost everything we see in the eye. It can lead to the injection. You can imagine the eye being pushed forward leads to a lot of poor, lubrication of the eye. And then this increased fixed pressure in the fixed bony orbit causes a retrobulbar pain, pressure, and the proptosis we see. But it's really this expansion of the tissue when we think mechanistically. When we look at this disease and begin to think about, well, what happens over time? In the last 50 years or so, and we've been thinking of that disease as an active versus what I think of as more of a stable as opposed to an inactive. But the active is when you have changes occurring. Sometimes they happen with inflammation, about 70 to 80%, but sometimes not. Sometimes it's just a gradual increase in eye bulging, but there's changes going on. And it's typically accompanied by inflammation. This eventually leads to an inactive phase of the disease. And one way of thinking about that is to ask patients, have you noticed any changes in your eyes in the last 6 months? And they say, well, sometimes when I wake up, they're a little puffier than when I go to bed. That's actually just normal day-to-day variation. But if they haven't noticed long-term changes, they're probably in the inactive stage. And in the past, we used this for treatments, a little less so now because of the new treatments that are available. And I'll explain what that's about. So acute and chronic TED. So acute is 2 years or less, changes. Chronic greater than 2 years. And in the past, we did, some medication early on and surgery late. That's changing a little bit now. We do have therapies that even can be initiated in the chronic phase of this disease and improvement. And then surgery typically is still relegated to the chronic phase. And I'll show you examples of all of these. Let's start a little bit with pathogenesis. Now, this isn't a basic science talk, but I think it's really interesting and there's only a few slides, because it really has changed and we understand so much more than we did just a few years ago. And again, it comes back to this heterogeneity of disease. How can all these people that look so different have essentially the same disease or a common molecular mechanism? And that's what, we really began thinking about, 10, 15 years ago. What's the commonality here? Well, it's kind of like a tree. If you look at a leaf of a tree and a branch of a tree or the trunk of the tree, they all look very different. And even one branch may look a lot different than another branch. There's similarities, but the commonality is that they have the same trunk. They come from a process that is dependent upon the trunk of that tree and then branch out with different phenotypes. And that's kind of what we've learned in this disease. The trunk of that tree centers around the discovery of the role of the insulin-like growth factor 1 receptor. It's essentially a receptor that controls the metabolism and the inflammation of these cells that are attracted around the orbit and the immune system around the orbit. Now, the IGF-1 receptor, which we'll call it, is overexpressed on these cells in particular. Probably it's a response to injury, and there are other diseases that probably do this, but the cells literally taken from orbital decompression overexpress this receptor like 50-fold. And then the signaling, from this overexpression of this receptor that's always turned on is pretty much like you've had your thermostat regulated too high in your house. It's just always running. The heater or the air conditioner but the heater is always running and building up essentially hyaluronan, extracellular matrix, inflammatory molecules. And what's driving this is likely antibodies to this receptor and the TSH receptor. It's just overexpression in not only these cells, but also the immune cells, T cells shown here, but it's the same in B cells. And this just drives that inflammatory process. And it's kind of unique in that these cells, these T cells, are much more frequent in Graves' disease, but not so much in other diseases such as ulcerative colitis, rheumatoid arthritis, etc. So it's a unique aspect and a unique process of Graves' disease. This is a fancy photo. It's not your Christmas, pre-Christmas photo, but it's actually a fluorescent photo where we mark IGF-1 with red and TSHR with green, and red plus green equals yellow. And what we found is that the receptors that drive the hyperthyroidism, the TSHR, just so happens to be a partner with the IGF-1 receptor. And this was totally unexpected and totally new because these receptors are very unique. But you can imagine this unlikely pairing of these two receptors on the tissue that is involved in the disease and antibodies that are stimulatory antibodies to these receptors drives that process forward. So mechanistically, we're really beginning to understand this just a little bit more and how this antibody or driven TSH, IGFR driven process leads to this cellular expansion, inflammation, etc. Now, this is a New England Journal article written by my colleague, Terry Smith, just kind of putting this in the center, where these cells, with the driving of the IGF-1 receptor and the overexpression, leads to all these myriad of things. But what it leads to in patients is it leads to expansion of the tissues, calling in of the immune system, even transformation of these tissues into myofibroblasts and other things were heavily scar oriented. And this is really important because the therapy that then went on to develop actually blocks this receptor and the both of these receptors actually, and then allows that thermostat to be turned down or turned off and to go back to its normal homeostasis. And we're going to get into that in just a minute. Now, I really, want to be fair and at least give you an overview of all the therapies that were available prior to January of 2020. And then we're going to spend a fair amount of time on the therapies available after 2020, which are the monoclonal specific therapy. So conventional versus novel treatment, it's probably not as novel anymore, and it's becoming more conventional, frankly. But the thyroid treatment, the treatment for thyroid eye disease really has to focus upon the underlying disease process. That's what we want to reverse, right? We want to reverse the double vision. We want to reverse the bulging. We want to put people like myself, orbital surgeons, out of business. And we want to reverse these long-term consequences of disease. And to do that, we have to think about, well, what treatments, exist and how does that compare to new treatments coming available? Well, UGOGO, which is a large European union, it's kind of a European organization just studying grade orbitopathy or thyroid eye disease, recommended steroid regimens for the last probably 30 to 40 years. And the current regimen was for a cumulative dose of about 4.5 grams of steroids over 12 weekly infusions. So you can imagine this is not an easy therapy. You're given about 500 milligrams of steroid or prednisone equivalent every week, and so these patients had quite a few side effects. That's really beginning to wane. The newer treatments are not available quite in Europe, so there still are some regimens that will use steroids in the countries where new therapies are not available. But unfortunately, what happens is that the steroids really don't reverse the underlying disease process. They don't reverse the eye bulging and the double vision. So you go through this entire process and you only maybe reduce the inflammation. But there's never been any measurable impact into the long-term improvement of the disease, either in the bulging or the double vision, and the things that really seem to matter to patients. And so it was done here in this meta-analysis, looking at all those previous papers in comparison to a novel therapy. This is just a demonstration of some of those steroid regimen papers, just again, kind of showing what I told you already, and that patients had lots of adverse events, but they unfortunately did not have improvements in their eye bulging. Shown here is a negligible improvement of 0.76 millimeters at week 12 after treatment, after being on steroids for this even currently being on steroids at the end of this treatment, there was very negligible change. So the steroids were not really a great answer for proptosis. This is just another pooled estimate from the baseline proptosis from that JAMA ophthalmology paper, and then the pooled estimates for double vision, also demonstrating that it doesn't really change proptosis and it doesn't really change double vision. And that's an important walk away point. There's just really not much change from this double vision. At this time, pre-2020, we were subjected then still having this side effect profile of glucocorticoids. And in the US, it never really caught on to use high dose steroids except in the most severely affected patients because of the side effect profile and because we felt that, these patients likely would have to undergo surgery anyway. And putting in the face of these side effects did not seem to be a reasonable thing unless their disease was truly sight-threatening and causing optic neuropathy. So the bottom line is that steroids did not reverse the underlying alterations in orbital tissue, and they don't reverse some of the other signs of proptosis or strabismus in so doing. We can see that there were drugs even tried, such as rituximab. And here, what we're looking at is a response of rituximab and methylprednisone, trying to look at, there's two studies that were in this in cohort. Really, in rituximab, even though it wipes out all the B cells in your immune system, it also does not really reverse the proptosis. There was not significant in either study demonstrating an improvement in proptosis. It did improve a little bit the inflammation, but again, most of that inflammation would come back up to 70% recurrence rate. So it was short-lived improvement. Tocilizumab, which blocks an IL-6 receptor, was also used for completeness. And this was done in a couple multi-center trials. Again, really is unclear whether in these small trials, whether there was really any long-term improvement of efficacy. I can say in about the 5 years or so since this last trial has come out, there really still is very little enthusiasm by experts to use tocilizumab unless it's just impossible to get specific inhibitors such as teprotumumab. So you can see that, these fancy names, tocilizumab and such, and steroids really led to a lot of disappointment in this field and stagnation even. And was really, had to have a new approach in thinking of a TED specific treatment. And for this specific treatment, it wasn't just treating the immune system by knocking out all the B cells or dampening the immune system with steroids. It was actually targeting of what the immune system was attacking, the antigen. The antigen is what the immune system is attacking. And in this case, it was the IGF-1 receptor, because we know that the immune system attacks this insulin growth factor 1 receptor because of all the reasons I mentioned before, because it's overexpressed, there's antibodies to it, and there's signaling. So we felt that this would be a very reasonable target to kind of turn the immune system into stealth mode, make that receptor internalize, essentially go way off the cell surface, and it won't be recognized by the immune system. Granted, this was a entirely simplistic thought process, but sometimes simplicity works, whether it was designed that way or not. And again, this just emphasizing that the IGF-1R is overexpressed, and what we're trying to do is to return those levels to normal so the immune system doesn't attack these cells. This led to a medication that was FDA approved in 2020 called teprotumumab. And teprotumumab, the mechanism of action is kind of what I've been leading up to. It's a fully human monoclonal antibody, and it inhibits the IGF-1 receptor. Actually causes internalization of this receptor, and it no longer leads to phosphorylation of this receptor. And it's specific in that it targets the IGF-1 receptor, but it also leads to internalization and diminution of the signaling complex, that IGFR TSHR complex that we kind of talked about before. And it probably blocks autoantibodies from attacking these cells. And so by turning off this signaling at the disease source and not being a target for the immune system, we thought, and presumably is, that it would reduce inflammation and prevent or reduce excessive cell growth and hyaline buildup behind the eye, essentially reverse the disease. And this is just a pictorial, looking at acute thyroid eye disease and even chronic thyroid eye disease. But in acute, we have, again, the TSHR, IGFR that's subject to attack. You can think that's going to be the target. And then the downstream on the lower end of this slide is all the things that happen when that molecule is attacked. Inflammatory cytokines, cells differentiate, increased hyaluronic acid. Essentially, you see all those horrible pictures. And some people have more inflammation than others, just the way they're born and the response they may have in this receptor molecule. And others may just have fat accumulation. So this also helps to begin to explain some of the heterogeneity that we see in this disease. And it just so happens that it doesn't really matter whether you've had the disease for a little time or a long time, you still overexpress this receptor complex. And this receptor complex is still present in high levels. And if you block that, you can turn down the set point and even reduce the constitutive production of all this hyaline and extracellular matrix, and allow those tissues to shrink, as shown on the chronic TED side. The study that was used to demonstrate this was published in the New England Journal of Medicine. There were two articles. The last one we published in the New England Journal in 2020. And it took patients who had a very defined group of patients. They had active thyroid eye disease, and they had it for at least 9 months or less than 9 months since the onset. And they had bad disease. They had at least 3 millimeters of proptosis, and they were given one of two things. They were either given teprotumumab, the IGFR blocker, or they were given placebo. And the placebo was just saline. And then they were followed, and there were 8 infusions. And this has to be given as an infusion at IV because it's a monoclonal antibody. And the primary endpoint was really disease reversal and more than 2 millimeters improvement in proptosis at week 24. And the results were pretty astounding. Even as the trial was going on, we were seeing remarkable improvements. And the primary outcome, proptosis responders, was significantly greater in teprotumumab, but also the amount that their eyes went back went far more than 2 millimeters, improvement in double vision, and even improvement in their quality of life that they experienced. This is just an example of a patient in the trial. One of my patients, actually, she was a placebo. It turned out to be a placebo patient, pre-treatment, and at week 24 being followed. Not much change. Maybe she even has like a millimeter tumor proptosis. Maybe the inflammation is subtly different, but not a whole lot of change when you give, IV saline. This is a gentleman who actually was almost going to stop running his family business because he could no longer see to get to work. Also, one of my patients on the left side, his vision was also becoming, impacted. He couldn't move his eyes. And you can see at week 24, a significant improvement. And this was actually even noticed when he came back in at week 6 of how dramatic improvement. He had about a 6 millimeter improvement in the bulging of his eyes. This is just a demonstration of the inflammation reduction. We call it the clinical activity score. We don't use it much in clinical practice, but it's used in research. This is demonstrating that the inflammation dramatically improved. It's a 7-point scale, and these patients improved a lot. The natural history is that they also do. So you can see in placebo, they also do improve a little bit also. What was really interesting was that the proptosis, the eye bulging, improved fast and throughout the course of this disease, up to 83% on an intent to treat analysis, demonstrated an improvement of at least 2 millimeters of proptosis. And it was fast, almost 60% at week 6. Again, also now demonstrating the magnitude of reduction. And early, you can see that there's about a 2 millimeter reduction as early as week 6 in the teprotumumab group. And this continues to get better and better to a little over 3 millimeter improvement by the conclusion of the study. Their MRIs, we also took on several of our patients and showed that the MRI, the muscles shrunk. So it really came full circle in that you really are having the fat and the muscle reduce in size by the treatment of this medication. So the mechanism of action, the things that we thought about early on were truly happening. We did 3D volumetric analysis on this. How about double vision? Well, double vision also responded pretty amazingly, and it was improved birth baseline double vision. And this was improvement of 1 grade of double vision that got better. But 53% of patients who had double vision, it went away completely, were treated with teprotumumab compared to 25% with placebo. Quality of life was also improved, as you can imagine, with patients in the blue, where the increase is improvement in the quality of life. Safety, those early safety numbers demonstrated that muscle spasms, some nausea, fatigue were present. Also, amenorrhea was noted in a few patients, and in hearing defects, which I'll talk a little bit more about, were noted in a couple patients, didn't meet the cutoff in those original studies. That's ear plugging was noted in a couple of patients. So the durability of response became one of the next questions. Well, how long does that last? Well, 28 and 60-week data after initiation of teprotumumab treatment, so being off treatment for up to 39 weeks, had proptosis responders up in the 80s, diplopia responders 60 and 78%, and 95% still had inactive disease. And this was part of a publication in JAMA, in the Lancet, the Lancet Diabetes Endocrinology, just demonstrating this data, both the proptosis and the double vision, and how that is relatively appears to be long-term improvement in the majority of patients. So how about acute and chronic thyroid eye disease? We just chose acute for the first initial few trials. There is much more data now, and also demonstrating that it reverses chronic thyroid eye disease. Mostly, it's still based upon the same mechanism that overexpression of the IGF-1R still exists in both of these patient cells. It's not just the immune system. It truly is these fibroblasts and these cells around the eye. demonstrating just that this is just a study demonstrating that in non-inflammatory TED or in chronic disease, you have very high levels of the IGF-1 receptor still available, still is the target, and that's why you're likely seeing an improvement. Just a schematic of how this is occurring. The stimulation still occurs chronically of this receptor, leading to constitutive hyaluron production. And this is a constant turnover process. So our cells are constantly turning over and they reach a set point. And what we're doing with teprotumumab is we're actually dialing down that set point and reversing this disease. And that's exactly what we saw in early studies that we did, demonstrating greater than a 3 millimeter reduction in proptosis over the course of treatment in patients that had long-standing disease. And there's been subsequent studies, prospective studies, also corroborating that finding of well over 2 millimeters of improvement in these chronic studies. So no matter whether you have patients who are just diagnosed or diagnosed, and the studies have gone up to about 10 years, it appears that teprotumumab can reverse the eye bulging in those patients. This is just one of my patients who had the disease for 20 years. And you can see on attempted upgaze before teprotumumab, the one that labeled attempted upgaze is part of a 9-gaze shot. And the one below that is just her looking straight ahead. It's hard to tell the difference because you can't look up. And after teprotumumab, you can see that on attempted upgaze, her eyes move. She also reduced her proptosis by at least 3 millimeters, but you can also see she was thrilled because now she could actually drive without the constant chin up posture. She was deathly afraid of surgery, so didn't even want to have strabismus surgery because she just didn't want to go through surgery, and she just, adopted a head position. But she put up with this for so many years, and then really had a nice improvement. The efficacy comparison is pretty similar to what we can achieve with decompression surgery. Now, I'll show you some examples of decompression surgery where we can achieve, various amounts, but it's in the range of, 3.5 millimeters for many, many patients. So how about tissue-specific effects? I'll go through this really quickly, only because I think it's really important to know, because most of your patients are going to come and say, the thyroid eye disease, yeah, it's the eyes, but my whole face has changed. And they are not wrong. The soft tissue changes are not restricted to the orbit. They have soft tissue expansion around the eyes, brow fat expansion. I often call it the hot dog brow. And then you can have temporal fat expansion. But most often, my patients hate the lower face. And look, we're in the eye care business, so we often don't ask them about facial shape changes. But when they open up, they really do. They hate how their lower face has become so bulky. And that's because of the increase in volume of the fat of the lower face, which no one wants. They also get retroperitoneal fat expansion, but that's probably a little too far afield. So what we did is a 3D photographic imaging technique to capture and see whether teprotumumab changed these people's facial characteristics. Do their faces go back to normal? And we used standard landmarks, and we compared pre and post conditions, and then divided into these various regions: lower, mid face, temporal region. But is it true? Does our surgery typically is focused around the eye, but what about the rest of the face? Well, this is a volume reduction after teprotumumab. And, one of the things it may be kind of hard to see is sometimes a little easier to see in the grayscale, but just the face overall really has a dramatic improvement. This is just another example after teprotumumab. And people feel that their face kind of goes back to normal instead of looking puffy, etc. May seem like a small amount, but in the full face, it was a full 8.5 milliliters or 8.5 cc's of fat change over this period of time. These patients, by the way, did not lose weight. Their weight stayed the same. And you can see that the lower face had quite a substantial volume change in addition to this change that we see around the orbit. So it truly is a facial disease, and it truly is something that these patients really do hate. In the remaining few minutes, I'm going to kind of now take you from the latest medical therapy, which is teprotumumab and now widely prescribed. And I'm going to bring it, so that we're complete in our discussion, talk about orbital decompression and what we can still do surgically. Because, even though, medication, probably now can achieve at least a 75% result in the majority of patients, there are surgical issues that still come up. And I think it's important to let you know what they are. Now, I think that it's very important that patients complain about things, you do a systematic approach and customize that approach. And I'm going to be very focused here and primarily on orbital decompression, but we do a lot of facial surgery to help with these patients. And it's really important that when a decompression is done correctly, it can really dramatically reduce the need for other surgeries or eyelid surgeries. And frankly, in the last 10 years, I've been doing all this eyelid, orbital decompression, and facial surgeries all at the same time. And it's kind of like a one-stop thing. The first thing is a little anatomy and to think about what we want to achieve. Well, when we want to move the eye back, we want an axial globe movement. We can shave down some bone here shown in the cloud of green behind this little plastic skull that is the left skull. And we can just kind of shave down some of that bone. You can do this through an eyelid crease incision, and it takes a little practice, but you can get very good at just kind of shaving down this bone. The eyeball kind of falls back into place, leads to an axial reduction. You can keep some bone in there are some technical things. You want to keep this bone intact to prevent the eyes widening, which looks a little strange. And in this type of decompression, you can achieve some very nice results. Now, I am doing less decompression, but I still do about 200 or so a year because a lot of patients can really benefit from this and do very nice 6 millimeter reduction in proptosis and no real additional surgery. So that's an axial reduction. It's just called often a lateral decompression. And it can also be combined with a fat decompression or eye lipo, is to use that term, but you can combine it and you can actually get very nice improvements. She still has some puffiness, still has some changes around the skin. Some of these were before teprotumumab because that's when we were doing the biggest surgeries, or surgeries tend to be a little smaller now. This is just an example of a gentleman who has impending optic neuropathy, who went through surgery and then had a little strabismus correction. Also, still can see some underlying, potentially some percolating inflammation, but dramatic improvement for him. The next is how we get a natural lower eyelid appearance. And that's often done by customizing the decompression technique and not doing necessarily eyelid surgery. Sometimes eyelid surgery is more dangerous than more decompression surgery. Well, instead of pushing the eyelid up for eyelid retraction of the lower lid, we can often just remove a little bit of bone and lower the eye. And again, bone taken here can be done through an eyelid crease incision all at the same time, and you just shave bone from a slightly different location. Well, what this does is without any eyelid surgery, it restores the normal lower eyelid contour map before and after decompression, kind of gets them back to looking normal. And this is often so much more aesthetic than trying to place a graft or something like that can be very obvious. This is just pre-op and post-op in a patient who had a decompression, no eyelid surgery, but now a much more normal eyelid contour and improvement over time. It's just a more dramatic example. And again, no eyelid surgery, just a single staged decompression surgery. She had quite a bit of a reduction with a 9 millimeter reduction because we did a full decompression, but really just kind of getting her back to normal by focusing upon what has the disease has done and trying to reverse those effects rather than try to fix an eyelid that hasn't really been affected by the disease. But what's happened here is profound proptosis. Just another example of a patient who also had a similar procedure done, just moving the eyes back, a little less traumatic because she needed a little less. And then finally, just another example of proptosis reduction and improvement. And I probably wish on the left side I would have released the eyelid just a little bit. I still think it's a 0.5 millimeter low. The next, and then when we think about restoring facial features, we don't want to again stop at just the eye. We want to make sure that the rest of the face continues to have this rejuvenation or return to what they look like. My patients never come in wanting to look like a movie star. They just want to get back to 75% of what they look like before, so they don't feel self-conscious to go out in public. And that's what we try to do. And you can do this even non-surgically. This is just a patient with filler who has thyroid eye disease, but relatively mild to moderate. And we can place a little bit of filler into the cheek area and kind of expand that and make that improvement. So the patient with a little bit more severe disease, you're not going to get away with filler so easily here. Also a lot of congestion, etc. But the lower eyelids, I will draw your attention to, and this orbitomalar ligament here is very pronounced. And so one of the things we want to do is give the cheek a little lift and get rid of that demarcation, especially while we're going through surgery to move her eyes back. So what we can do is we can move her eyes back, do the proptosis reduction, and also try to improve that cheek at the same time using surgery just for a little cheek lift. Example of a patient with just one eye that's bulging on the left and on the right afterwards, just an improvement of that cheek junction, moving the eyes back, and then in addition, trying to improve that lower cheek junction and make it just so that no one can tell that she had this disease. And another example where there's a lot of lower eyelid retraction, the lower eyelid, and a lot of scleral show. And we did the best that we could of really trying to dramatically improve this. But her, she went through so much where she wouldn't even go in public just because of the appearance of her eyes. And again, she wasn't looking for a cosmetic result. She was just hoping to get some back to as close to her normal as possible. Sometimes we're faced with patients who just don't have a lot of bony support. This is a gentleman with thyroid eye disease and mid-face hypoplasia. He just doesn't have a lot of bony cheek to really help with this. So we can use implants and a little augmentation and slide this implant in through a lower eyelid incision. And then we can dramatically improve his cheek, lift up the lids, and move the eyes back all at the same time. Just an example. Just another example, very similar gentleman, again, hopefully looking natural and more like himself, moving the eyes back and then placing in a little cheek implant here. Now, when we do this in single stage, sometimes you want to address the upper eyelid and the eyebrow. I apologize for the blurriness of the photo, but you can see in the upper eyelid, there's upper eyelid retraction and significance in addition to proptosis. And we can lower the upper eyelid at the same time. Sometimes I do this under sedation and then put them under general so they can open and close their eyelids, but then move the eye back. And we can do that all at the same time as a single surgery now for an improvement. There's also other cases where we want to reduce the brow fullness. So the pink, it can also be shaved away, just to make sure you don't get into the brain, because that is very close, but it's still a very nice safe zone. And you can make a little bit more room for the eyebrow or the lacrimal gland that's here. And in a case like that, that's really important. So this is a young girl who I've actually just saw more recently, and now she's an MBA. And hopefully taking over the tech world. But in this particular circumstance, she was right before that schooling, and her appearance dramatically changed. This is her photos from before she had thyroid eye disease. So you can imagine how devastating this was for her. She had an eyelid crease, very normal upper eyelid, normal, cheek anatomy, everything. But now she has profound eye bulging. And what we're trying to do is to move this eye back and hopefully do it without making an incision on her eyelids, which we also can. And in that way, what we want to do is we want to do everything from inside the eyelids and do the little blue dotted line, a periosteal dissection, and get behind that, and then just take away all this bone. At the same time, we might want to lift up her cheek shown on the left-hand side of your diagram, the right orbit, and then just lift up those cheek fibers at the same time. But for her, we want to do this without making a skin incision. This is just the periosteal incision that we can do, and we can do this from inside the eyelids. And then no skin incision, no orbicularis incision. And this is just, her improvement afterwards. She moved her eyes back about 5 millimeters, had an eyelid crease. Again, probably not back to her normal, but now she felt very comfortable. No more pain, pressure, felt more symmetry. Previously, her right eye was quite a bit more bulgy than her left. And, just an improvement that now she feels much more comfortable opening and closing her eyes. And again, also pretty large reduction in the amount of bulging, especially when you see from the side profile. It's another example of a patient who had a little bit more bulging in one eye than another. What we're trying to do here is a single stage surgery to improve her symmetry and move her eyes back. So the final concept in PHI is to do this simultaneously, address the orbit and the face, all in a single stage. And I'm only going to show you a couple patients and we're going to conclude. This is just a patient where, okay, she has thyroid eye disease, but she also doesn't like her lower eyelids, doesn't really love her upper brow. And so what we've done here is that we've done a buccal fat removal starting from her down in her buccal fat area and narrowed that face. And now when I do that buccal fat is I transplant that into her cheeks. But I can also do a lower lid blepharoplasty where I take the fat and smooth that out onto her cheeks. Most of that's again caused by thyroid eye disease. Do a decompression, moving the eyes back about 3 millimeters here, and then elevate the brows and the upper eyelid blepharoplasty to give her result. And then she's about 5 years out and has done exceptionally well, and still keep in contact with her. She lives in Spain. This is just an example of a patient who actually was on the doctor's TV show with me. And for her, she had asymmetric disease, but also bad disease. And what we did here is a decompression, a little bit more on the right than the left, released her upper eyelids, did a buccal fat removal and fat injections to the cheeks to be able to move her eyes back and to give her an improvement. And she's only about 4 weeks out of surgery here. Usually there's about a 1 to 2 week recovery, usually about a week, and then you're back to work with outpatient surgery. This is a gentleman from Australia, very similar, situation. Needed a decompression, the best we could do, but also had a really flat mid-face. Thought we could give some fat injections and then move some of that fat from his lower face up into his upper face. And then our final example is just a very thin woman, very asymmetric disease, did a much bigger decompression on the right side than the left side to give her some symmetry, and then also move some fat around because she was just so thin, especially through her cheek area. So in summary, in the surgical side, the aesthetic result is critical to patients. They really want the best result they can get. It's outpatient surgery, and done in the right way and in the right hands, the risk of double vision is usually less than 5%. In many of these cases, it's about 1 to 3%. And we can simultaneously address each component. Now, the conclusions to the talk, I do want to come back to medical therapy so that you can walk away and understand that steroids do not reverse the underlying alterations of orbital tissue or proptosis. And the teprotumumab now has really kind of emerged as the frontline therapy, both recommended by the ETA, ATA, because it can significantly reduce proptosis. And frankly, some of my large surgery sides like this are getting a little more dated because teprotumumab is so effective, and my surgeries are getting much smaller. Probably I'm doing 75% less surgery for the patients that I operate on. Still doing a fair amount, but it is becoming a little bit more aesthetic. And again, specific to diseased tissue and its proven efficacy in chronic thyroid eye disease also.